So we're going to look at the German healthcare system. And the one reason I picked the German healthcare system will become immediately obvious to you all. And that is, like the American system, it has multiple competing health insurers. And that provides at least as close a template to the United States as you get, since we have some competing systems, as you understand, in Medicare, certainly in commercial insurance and the exchanges. That we can learn some things from Germany, at least 3 or 4 things that might be useful to improving our system. Let me just remind you, you can put questions in the chat. Patricia, who works with me, is monitoring that chat and will interrupt so that you can ask that question, especially if it helps clarify what points we're making. So don't feel shy. I've built in plenty of time for that. So for those of you who will not get to the bitter end or want the punchline up at front, there are multiple advantages. Here we list 6 key advantages of the German healthcare system. First of all, they have multiple competing sickness funds, and the sickness fund is simply their phrase for an insurance company. I should put competing in quotes. They are competing for members, but how much they compete for quality and how much they compete on keeping costs down is less clear. But it does mean, and this is the second point, that German citizens and residents get free choice of sickness funds. It used to be a sickness fund was associated with a specific employer, and they had literally thousands of sickness funds because they had thousands of employers. But they've now gone to a lot of consolidation, and they're no longer employer based. So you work for VW and you have the VW sickness fund. You can choose any of them. You can buy the Mercedes-Benz sickness fund or the BMW sickness funds or what have you. In addition, there is free choice of physician and hospital. Literally, a German resident can go to any doctor, any hospital in the country. There's unlimited physician visits, as one of the officials in the American Medical, their version of the American Medical Association told me, if I've got a orthopedic problem, I can literally, as a German, go to 10 orthopedists in a day to get 10 separate opinions. And there's no penalty for that. Indeed, copays are low, and so the barrier to doing that from a financial standpoint is pretty low. So if you're retired and you just have a lot of time, great. They have low copays throughout the system, and in some cases, no copays. They have drug price negotiation and regulation, which is slightly different from many other European countries, as well as Taiwan and Australia, and we'll describe that. And then, unlike almost every other country that we looked at, unlike the United States, Scandinavian countries, only Netherlands, like Germany, has a dedicated financing for long-term care, for elderly who can't stay at home and need either nursing home or care at home. So just one slide on the history. I find this history fascinating. Germany is often considered the foundation, the first to develop health insurance and compulsory health insurance. And that began in 1883. For those of you who studied any history, 1883 in Europe and North America was a time of a lot of uncertainty and churn and of a lot of domestic controversy and conflict. That's because of industrialization. And they created compulsory sickness funds, compulsory health insurance, initially to cover urban industrial workers, which was only about 10% of Germans. This man to the left, anyone know who he is? No? All right, we might have to come back. He was, to get his name, he was a prime minister or chancellor of Germany, and he developed this compulsory sickness funds. Now, what's surprising is he developed this compulsory sickness fund as well as worker unemployment insurance and pensions, even though he was very conservative. His name is Otto von Bismarck, and he developed it because of the militancy of the industrial workers striking, being attracted by the socialists and communists, and he wanted to deflate that and create the kinds of social supports that those workers were demanding. Initially, there were, that says merely, but there were nearly 19,000 sickness funds associated with each employer, as I mentioned, thousands of them. They mainly focused on lost wages from sickness, not on covering health services, because the lost wages was the real economic impact. Eventually, at the turn of the 20th century, they began covering medical services when medical services became much more effective and worth paying for. And they, over time, over the next century, really, they began covering all workers, and the last workers covered there were farmers. It's financed initially by an employer and employee payroll deductions. That's how he devised it. The employer would pay some, the employee actually initially slightly more, and employer-employee would have some say over how the funds were distributed. Does that financing mechanism remind you of anything? This is an open question. Someone can unmute and answer it using a payroll deduction.
Somewhat sounds like health insurance.
Yeah, it's like health insurance. So we have a payroll deduction, taxes to finance Medicare Part A. We also use it to finance Social Security. This is where it all started, Otto von Bismarck. And what's interesting is I talk about in the book path dependence, that is, once someone establishes something, a lot of people just keep copying it. And this is one of those good examples, the payroll, employer-employee payroll deductions to finance these social support mechanisms. Here's the coverage today. Germany has a population of roughly 82 million people. They have a statutory health insurance. Did I miss a slide? A statutory health insurance system that covers 87% of the population. That's workers in private industries, as well as people who aren't working. Then they have something that runs parallel called the private health insurance, which is much smaller, only 11%, and targets government officials. So the people in the legislature who vote for statutory health insurance, they don't get it. They get this private insurance. Civil servants, they also get the private health insurance. People who are self-employed, who run their own small businesses, and then rich people, people earning above 57,000 euros 3 years in a row can opt in. There are about 109 sickness funds, and again, there's been tremendous consolidation. There may be less than 100 today. This number might be a few years old. And there are 42 private insurers. And then for policemen and soldiers and asylum seekers, there's private. So the sickness funds today, there's an insurance mandate. Everyone has to have health insurance. And there, unlike America, there's a serious mandate. People have free choice among the 109 not-for-profit sickness funds, then they all have to be not-for-profit. All the sickness funds have to cover the same benefits. So like in the United States, we have 10 essential benefits. They have a similar, actually more detailed system where all have to cover it. And they have to cover all the physicians and hospitals in the country, which is why any individual has free choice of any doctor in the country, any hospital in the country. So if I have, say, a serious cancer and I live in, call it Frankfurt, but I want to go to Berlin to get the treatment, I can do that, and the sickness fund will cover it. There are variable premiums, so you will see they get most of their money from the government, but they charge a small premium to people. That small premium is dictated by their costs, and it varies among the sickness funds. So there's mainly the payroll taxes funds, most of it, but there's also these low premiums. Private and health insurance, as I mentioned, is different, covers 11% of the population. It's separate. There are 42 of these private companies. It's for the self-employed, as I mentioned, civil servants, politicians, and the well-off. Those who have high earnings can opt out of the statutory system and get private insurance. But getting into private insurance is a once in a lifetime decision. It's a one-way door. Why do you think they made it a one-way door? It's not a one-way door in other countries. For example, in Australia, you can go back and forth. And by the way, you can simultaneously use the private and the public system. In America, interestingly, veterans can use simultaneously the veteran system and Medicare. So there are lots of countries where there are simultaneous use. But Germany wanted to make sure if you opt to private, you can't go back to statutory. Why is that? Why do you think? Just put your German administrative bureaucrat hat on. Why would you do that?
Is it a funding thing so they can kind of keep track of how many people need to be covered?
It is a funding thing. So it's you have a good intuition, which is when something is done, think of the money, especially in healthcare because it's so big. But it's not just to keep track of. It's mostly because once you're in private insurance as a well-off person, you pay a premium and they still get your payroll tax. So they don't want to cover you. They don't want a situation where you're very expensive and suddenly your premium might be high, and then you're going back to the statutory scheme only when you're expensive. You may know that kind of problem as adverse selection. So they want to cut down on adverse selection of people when they're cheap going to private insurance and when they're expensive shifting back, to the statutory health insurance scheme.
So I have a question about an individual who does this one-way direction and opts for the private insurance and their financial circumstances change. Are they stuck for life?
That's why they make it 3 years in a row. You have to show the high pay, okay, a high salary. There are exceptions, real duress, they will, but in general, yes, it's one way. So they want people who have, basically 3 years in a row, secure, high-paying jobs. But, if there's a serious recession, even those people can be hit. So overall, Germany spends 11.3% of its GDP on healthcare, 5,200 per capita. The United States, on the other hand, is closer to 18% of GDP, high 17%, 11,000+ per capita. The statutory health insurance scheme, all those 109 sickness funds account for not quite 60% of the total expenditure. And patients under private insurance generally pay providers first and then get reimbursed. This is the old style payment system. Now, those of you who have private insurance know, right? Your insurer pays the doc and then you get the balance bill, whatever that your insurance company isn't necessarily covering. The German system is old style. It's mostly the way the United States was in the 60s, which is you pay the doc and then the insurer pays you. So here's how it looks. This is the statutory health insurance scheme. Employer contributes 7.7% of the worker's income. Employees contribute 7.7% of the income under this opt-out threshold, which again, roughly $63,000 a few years ago. And then the federal government takes general tax revenue for any shortfalls. It goes into a central reallocation scheme. Basically, all the money gets in, they shake it up, and then they distribute it to sickness funds based upon their enrollment. And then, as I say, you see number 4 there, sickness fund enrollees. That's the premium people pay. They make up around 10% of the expenditures. And then patients have some out-of-pocket co-pays, mainly for pharmaceuticals and some physician office visits. That's a 3% of the total. So the vast majority of the money, 85–90% comes from these employer contributions and government general revenues. The sickness funds then take the money, pay the hospitals, physicians, pharmaceuticals. You'll see this payment to physicians is complicated in an interesting way, meant to keep the whole system under a budget cap. Now, here's one of the more interesting differences from the American system, and I think one thing we ought to consider: family coverage in the sickness fund system. So children and non-earning spouses are covered at no extra cost to the worker, i.e., the worker still pays 7.7% of their salary up to the cap. If they have a family, they don't pay more if they're than a single person. So there is social subsidization of children and non-earning spouses. Unlike the American system, where if you're an individual, right, and you're an employer-sponsored coverage, you pay one rate. And if you're a family and you're getting family insurance, you pay much higher in our system. The Germans do not have that. They view children as a social cost and something that society should pay to encourage, or at least not put all the financial burden on the individual family. In addition, if you have children, there's no copays. So going to the pediatrician has no copays, and there's reimbursement for over-the-counter drugs. You need Tylenol for a sick kid with an ear infection, that is reimbursed to you. Okay, so these are generous financial coverage of children, and the German fund in this, the German system in this regard is not that unusual. This covering of children at no additional cost to families is quite common. Payment to hospitals. Payment to hospitals are based on diagnostic related groups. We developed that here in the United States, and it's been used throughout the world. And typical, there is some slight payment for performance reimbursement to encourage increased quality, and not a whole lot, and it's not been very motivating or incentivizing. Payment to doctors. I already promised you this is slightly unusual, and it's actually worth thinking about. So there's pre-negotiated regional budgets based upon the anticipated billing points for services. Basically, what happens is doctors see patients, then they convert their seeing the patients to points. These points are then aggregated quarterly and sent in. Now, the regional budgets are divided, specialists in one hand and primary care doctors. It's a method of making sure that if specialists run up the bill, they don't take money from primary care doctors. The sickness funds then pay not directly to the doctor, but they pay to the physician association, like the AMA. It's as if the sickness fund says, okay, you AMA, you're going to pay the doctors, and we're going to give you the money to pay. All right. So the physician association get the billing points, and they get the money from the sickness funds, and then the physician association pays the individual doctors based upon the submitted bills. Now, the payment to individual physicians is based on a set scale, and they're the same scale throughout all the sickness funds. There's no variability. So Volkswagen sickness funds pays one, and BMW pays less, and Mercedes-Benz pays even more. That doesn't happen in Germany. All the sickness funds are on the same uniform value scale. So it tells how many points get how much money. All right. You know, if you've been following the news, that private insurers in the United States, the same procedure, right, or the same activity, radiologists reading an MRI, vastly different amounts of money depending on who's paying, whether it's Medicare, and then which commercial insurance pays. They might have a better deal with United and a lower cost deal with Independence Blue Cross. That doesn't happen in Germany. So in most states, it turns out, most of these regional budgets, physicians submit more points than the budget has money for. So payment, it turns out, if I submit enough points for $1,000, because all the other doctors are also submitting points and we exceed the cap, there's more points that would require payment than there is money given to them. It turns out I only get 90 cents on the dollar. So if I submit for €1, I might only get 90 cents on that. And this is a way of the German system staying within a budget. Yeah, doctors might submit a lot more, but the system isn't going to pay the doctors a lot more. It's going to actually lower what they pay. Now, the German doctors hate this because I've already rendered the services. I did the services and I thought it was going to be paid, $50, but now you're paying me only 90 cents on the dollar. I'm only getting 45. I'm not going to harm my patients by not treating them, but I'm going to lose money. That's a big complaint by the doctors.
Zeke, we have some questions coming into the chat.
Great.
So Daniela, if you could repeat your questions about covering children.
Yeah, sure. So I guess I was just wondering, when you were talking about countries offering healthcare for like no additional cost to those to children and to spouses, whether or not there might be more incentive then to, or like less of a hesitancy to have more children because costs of healthcare might be a barrier to some individuals. So do we see that those countries have higher numbers of children per family? And yeah, that's just something that came to mind.
No, I think it's a fantastic example and a fantastic point. Right now in the reconciliation bill, Biden is trying to lower the financial burden on families with children by, for example, capping childcare costs at 7%, providing a child tax credit and things like that. A lot of countries do this for partly the reason you say, which is let's reduce the financial burden on families. Hopefully that'll encourage families to have more kids. Because so many different things are being done, it's hard to say. Nonetheless, in general, in Europe, that does these things, they have, mother and often father time off almost a whole year. They have subsidized daycare. It turns out their reproductive rate, the number of kids per family, tends to be under 2 throughout those countries. So if it works, it doesn't work well enough to get the reproductive rate above 2.
Yeah.
But it's a great question, and I think that they are those countries have the motivation to some degree. They have the motivation you have mentioned. They would like to increase reproduction, and lowering the financial burden of having kids is one way they try to incentivize it.
Right. Interesting. Okay, great. Thanks.
Another question there, Patricia, or not?
I think Jackie had a question actually.
I do, thank you. And I'm just sort of wondering, what is standing in the way from the United States having a model where we have a uniform pay scale for services, something like taking the model of Medicare and establishing that? I know there are all these private insurers in the middle, but do you see that as something we could do in the United States?
I think it's something we should do because we have tons and tons of gaming of the system,
Right.
but we have yet to do it. And I think there are big barriers. Hospitals think they do make a lot of money by playing this game. They're incentivized to concentrate, and that jacks up their prices a lot. So I think there are barriers, but I think what strikes me as crazy is that the people who pay for the variable prices are employers. They really get fleeced, and they have not banded together and say, listen, we want a uniform payment rate. Excuse me. And it's shocking to me that they haven't, and it just reflects how stupid they are in their negotiations and how they've structured their insurance. They just haven't focused on it. So
Right, that's really
both.
good.
I think
Mhm.
that they I don't know if they're bored or someone said to me, well, they're bored. They just don't want to focus on healthcare. I think it's really, they don't understand it. They don't hire people. They hire consultants, and consultants don't get money by lowering costs for them. They get money by raising, telling me, oh, this is going to be great. But the insurers actually make more money by selling more expensive insurance to employers. So
Right.
the motivation for actually lowering costs is not that great.
And so many patients get caught in the middle of that.
Yeah, of course. All right, let's talk about the private insurance side. Remember, this is for self-insured government officials and bureaucrats politicians, and well-off people. Payments to hospitals are also based on diagnostic-related group. They have slight pay for performance, and they are people are assessed for amenities, single rooms, etc. Ambulatory physicians are paid on a fee-for-service scale. They don't have to. They can pay more than the uniform value. Drug price regulation. So Germany is unique. Let me, I don't know how much you know about other countries, but in England and in Australia, those are two good examples of countries that use cost effectiveness analysis. So how much does the drug improve health? And we're going to peg our payment to them based upon that level of improvement in health. So those are countries that use this sort of objective standard of health improvement based upon research and studies. That's one approach. Another approach is what's called external reference pricing. And that is a mechanism by which, well, you're going to sell me drug A. Let me look at what other countries are charging, typically a basket of 6, 8, 9 other countries. And I'm going to peg my price to those. Sometimes it has to be among the 3 lowest prices, etc. Germany has a, separate from those, has a different approach. And that is, initially, there's a drug approved for marketing. So they have either through the EMA, the European Medicines Association, or this Paul Ehrlich Federal Institute for Pharmaceutical and Medical Devices, an assessment about the drug's effectiveness and safety. And if they say, yes, the drug's effective and it's safe, it gets approved for marketing. That's equivalent to our FDA saying, all right, it's safe and effective, we're going to approve it for marketing. And then in Germany, a 12-month period starts. During that 12-month period, the pharmaceutical companies can set the price. So they want to charge 10,000, they can charge 10,000. During that period, for the first 6 months of that period, the Federal Joint Commission, that is the insurers, the doctors, and the public, all of them have representatives. They review data on the drug, its effectiveness compared to other drugs available for the condition. So say I got a drug for lowering cholesterol. Now they assess that drug. If the drug is therapeutically similar, it's another statin, and the differences are minor in the research, they then reference price it to other statins. Okay? So if I got a new drug and it's no better than the statins, the price they're going to settle on is equivalent to the other statins on the market. What if the drug is therapeutically superior? I find a new treatment for a cancer that hitherto there's been no effective treatment, or my treatment is 20% better than existing treatments on a cancer. So the drug is deemed by this Federal Joint Commission in the research as therapeutically superior to the existing drugs on the market. Then you start a negotiation between the pharmaceutical companies and the Federal Association of Sickness Funds, not the Joint Commission, just the sickness funds, because the sickness funds are ones who pay for the doctor. If they agree upon a set price based upon how superior it is, how many people are going to use it, at the 12-month mark, 1 year since the drug was approved, the price is set on the negotiation. That happens most of the time, 85% of the time, that's how it goes. 15% of the time, we can't come to an agreement. The drug company wants more, the sickness fund less, and they can't sort of settle it. Then there's an arbitration that happens over the next 3 months, each of them giving their view, and then an arbitration body sets the price. So that's how the German system works. It's a little different than ours. What is appealing is that drugs of similar effectiveness, all those statins, roughly the same price. Drugs that are superior because of their superior health benefits get a higher price. So you can look at the percent of the GDP and average prescription drug prices compared to the US drug prices. And here, can you see here is Germany. Okay. And what you can see is that average ratio of prices in Germany compared to America, about 35%. Ratio of the GDP spent on drugs, about 75%. So they spend both less, Germany spends less, and the prices are lower. Okay? So this system works, at least if you think the American drug prices are excessive. So you can also see Germany prices versus other countries. Compared to Germany, our prices are sort of 2.8-fold higher. This is for brand name, not generics. Brand name, we have the world's highest prices. Generics, we have among the world's lowest prices. Our, for example, generics are much lower priced than the generics in same exact generics in France, just as an example. What? We have a question? And this gives you a look, US price per bill unit, Germany. So you can see much cheaper. Humira is this drug that is commonly used for rheumatoid arthritis. Lucentis is for eye problems. I don't know all these others, but you know, substantially less. All right. Now we're going to turn to long-term care. As I mentioned, you know, anyone have an idea as to who pays for long-term care in America? Anyone? Did I see Jem Johnson is ready to talk?
Would it be Medicare and families?
Well, half of that's right. Which half? Ben Krieger. Which half of that statement was right? You were sleeping there, huh?
Ben just chatted Medicare.
Wrong. Okay? In America, Medicare does not pay for long-term care. It pays for skilled nursing facilities or nursing homes. After an acute hospitalization, you can go there, but it does not pay for long-term care. Medicaid pays for long-term care, and Medicaid pays, but only if you're poor. And so if you're a middle-class American, you actually have to spend down your assets, become poor to qualify for Medicaid. And then most of the cost is borne by families, either someone taking care of the older person or paying someone to come in and take care of them. We are not unusual in the fact that we have a what you might call a jerry-rigged multi-payer arrangement without a stable funding source for long-term care. As I mentioned at the start, most countries have this sort of jerry-rigged, you know, baling wire, tape, chewing gum method of paying for long-term care. The two exceptions are Germany and the Netherlands, both of which have similar systems. So the system I've described is not exactly identical to the Netherlands, but pretty similar, certainly on the financing side. So Germany has a mandatory long-term care insurance, which is financed similar to health insurance, a payroll tax. So they have added on to the health insurance payroll tax, a long-term care payroll tax. So employers and employees each pay 1.275% of wages to long-term care. Pensioners, that's people who are retired, pay 2.55%, and childless adults pay an additional 0.25%. We're going to come back and you might think as I review, why do childless adults pay more? Supplemental private long-term care insurance is subsidized by the government. Family in-home care, they can apply for reimbursement to this long-term care budget for providing in-home care. So the United States, through the Reconciliation Act, is thinking of creating a dependent and child care tax refund. We do it as a tax refund, but in Germany, if you have dependent care and you're providing care, you can apply and be compensated, not get a tax refund. It's just a different way of paying for it. Professional home care is paid to the home care agency, and they go into patients' homes or older people's homes and take care of them where appropriate and where it's justified. And then there are nursing homes, and the nursing homes, to the extent that they exist, get a per diem payment. In every country, nursing homes are the most expensive way to keep old people and provide them long-term care. That's only for the typically for the sickest and most dependent. In general, the motto in long-term care around the world is what's called, we are slow in the United States at this, but in general, it's called aging in place. You got an apartment or you live with your family, people want you to age there. And the reason is it's much lower cost than moving you to a facility like a nursing home. Those tend to be both very expensive, patients are very sick, and they tend to die there very quickly. I mean, we talk about nursing homes as a place. No one wants to go to a nursing home, and the half-life, how long the average patient lives in a nursing home before they die, is measured in months, not years. The delivery system, as I mentioned, patients under the statutory health insurance plan, this is for 87% of the population, they have free choice of sickness funds, hospitals, physicians, anywhere in the country. Low copays, they're low to zero. Low-income individuals, patients with high health needs, children under 18, exempt. The average German exempt once they've spent more than 2% of their gross income on copays. Those with chronic illness exempt once they exceed 1% of gross income. So you got cancer, you are exempt once you have these high health needs such that you've spent more than 1% of your total income. These copays are insignificant, 3% of the total expenditures. There's no gatekeeping, and as a result, you don't have to go to the primary care doctor to get a referral to the orthopedist. You can schedule yourself with the orthopedist, and there is therefore a high demand on specialists. So here's what you can see about the delivery system. Look at hospitals. There's way more hospital beds in Germany than the United States, way more admissions, and the average length of stay is way longer, almost 40% longer than in the United States. What problems can you imagine for Germany as a result of this situation? Anyone? Do I have to call on someone? Faye, what problems do you imagine for Germany because of this situation?
Well,
Take a guess.
I guess. I would say that I don't know.
All right, Timothy, you got an idea?
Similar to what other people have said, I mean, obviously the ratio is quite higher per 1,000 people in terms of admissions, which seems to suggest that people are using the hospital more frequently on average.
Someone, can you mute? Yeah, thank you. Keep going, Timothy.
And so obviously, as someone I think indicated in the chat, there seems to be more pressure, at least upon the hospital system, or at least people are utilizing it more frequently. Perhaps because of some of the things we've said about the barriers being lower to entry. But yeah, obviously more stay, longer stay requires more resources.
Yeah. Romy?
That's the simple.
Okay. Romy, do you have another idea? Am I mispronouncing your name?
No, that's right. I was also going to say cost and resources.
Yeah.
That was
So
my-
have you guys experienced the idea of supply induced demand? Anyone know what that means? Renee? Tell me what supply-induced demand is. Renee. Rennie, is that how you pronounce it? Am I mispronouncing your name? Avoiding me. Daniel
I can
Lynn,
take this one.
what's supply-induced demand?
I would assume that supply-induced demand is, with more beds, it leads to more people wanting to use these beds or something of the sort. Yeah.
Which kind of people wanting to use them?
Old people. I'm not sure.
So in supply-induced demand is the idea that if you have more doctors, they are going to generate more use of their services. For example, take cardiologists. It's well known that if you have lots of cardiologists in an area or community, they tend to do more catheterizations, more echoes, more stress tests than if you have fewer cardiologists. It's a way of making money and using the resources you have, whether it's personnel or hospital beds. So one of the consequences in Germany of having a lot of hospital beds, they think, is they have more hospital admissions. We got the bed, put a patient in there, instead of, working them up, finding out, what's going on an outpatient basis. They put them in the bed and they do all the tests in the hospital. Or in Germany, they think this has led to a large increase in surgical procedures. Now, you might also imagine that there's an advantage to this. One of the advantages was during COVID, when you had this big bulge early on of patients requiring hospitalization for COVID. Turns out Germany had a lot of spare hospital beds. They even were able to provide beds for Italian patients and Dutch patients coming over from the Netherlands. In an emergency like COVID, it turned out to be an advantage. But in regular times, the normal, having a lot of beds may induce a lot of utilization and surgical procedures that might not be necessary. Okay. There are 150,000 physicians for 82 million people, about 45% primary care. Now, your image of Germans may be, they're sort of stiff, silent, long-suffering types. Wrong. They go to the doctor a lot, and they use psychologists and psychiatrists a lot. They have 10 visits per person per year. That's very high certainly compared to Americans. I don't know. There's no one on this call who uses 10 visits per person per year, I would venture to say. Unless you have multiple chronic conditions, you're very unlikely to be doing that. And it's certainly not true across our whole population. In addition, I note here, very limited selective contracting. They don't really have physician networks. Doctors cover sickness funds cover all the doctors. They have not created a situation where, all right, we're going to have only high-performing doctors in hospitals. We're going to give you a break on your premium, etc. Very few sickness funds have gone this way. Long-term care, from a provision standpoint, nearly 3 million Germans receive long-term care payments. That's 3.6%. 55% of Germans are over 80 years of 55% of the Germans over 80 years of age receive payments. That's not surprising. The wheels are falling off once you get older. More patients with Alzheimer's, more patients with multiple chronic conditions. About 70% receive payments for in-home care. There is payment to their family members for taking time to care for them. 30% go to nursing home institutional care. Ambulatory long-term care mainly provided by private companies. So this is where the profit motive comes in. Institutionalized nursing home care is not for profit. So companies are getting someone coming into your house to provide long-term care. That's a for-profit company that does that. On the other hand, going to a nursing home, it's a not-for-profit arrangement.
Zeke, we have some questions and comments about supply-induced demand. So
Oh,
maybe
great.
Daniel.
Yeah,
can start with
fire
your
away.
comment.
Okay,
Nathaniel, I don't know if,
please ask your question, Nathaniel.
Oh, I mean, I just had a comment about supply induced demand. It could be, if you just look at that graph or the table that you showed, that perhaps the US is not helping everyone, is not giving a bed to everyone who needs a bed. And Germany is. Now, you just explained that that's not true, but that was my comment.
Yeah, no, and fair enough. Just showing that there's more utilization where you have more physicians doesn't say, well, maybe there are more health problems that need addressing. But when you look at that, okay, and you look at sort of big areas like Miami Beach and compare it to other areas with similar numbers of elderly people, and you can control for all these socio-demographic factors, it does turn out that an independent predictor of utilization is the number of physicians or the number of hospital beds or the number of NICUs. So one of the things Patricia on this call has done is pulled up some papers that it turns out that communities with more NICU beds, surprise, have more NICU admissions. Now you might say, well, maybe that's because they have sicker people and that's why more NICU beds are built. It generally doesn't go that way. It goes the reverse. But it's a good thought, and teasing out which one it is extremely important. But remember, I'll just give you one story here as we're getting close to the end. When I was training as a breast oncologist, and once we were going around and the doctor said, after we gave the first, we completed chemotherapy on a patient, so they got all 6 cycles. And the doctor said to me, I was in training, and said, you should see this patient every 3 months before in the first year, and then shift over to every 6 months in the second year and every subsequent year. And I said, well, why are we seeing the patient every 3 months in the first year? That's the chance of the cancer coming back in the first year after chemotherapy is really low. And the answer was, that's how we do it. There's no evidence it's better or worse. So a doctor can decide, how often do you see a patient with high blood pressure back in the office? Is it every month, every 3 months, every 6 months? So that's where supply, the doctor's deciding. Well, the doctor might decide, my office visits aren't filled up, between 10 and 10:30, I have a blank space. I'll see the patient with hypertension this coming month, right? So that's how supply-induced demand comes in, and why most experts think it's a big part of healthcare. And in Germany, when you look at how many Germans get surgical procedures compared to other countries, it seems to be too high. And Germany compared to other countries, I could have given you, compared to the Netherlands, compared to France, compared to Norway, they have many more beds per person. Germans like their hospitals. And the hospitals, so it's a funny system. We didn't go into this, but in Germany, the local community pays to build the hospital. And no local community wants to give up its hospital, just like in America. No one wants to give up their hospital. And so, but once they put up a hospital, then it's the sickness funds that have to pay for the operations. So that's how you have this sort of feedback loop. Germany's using having the appropriate number of nurses for all hospital beds as a way of trying to reduce the number of hospital beds and hospitals. Not do it directly, but do it indirectly. Like, you don't have enough human resources to provide high quality care, therefore you can't have those beds. That's been their method of approach to closing hospitals. Other questions?
Sukalpa had a question. Sorry if I'm mispronouncing your name.
That's perfectly fine. Yes, I was just curious, since people could kind of direct their own care to and go to any specialist they wanted, based on their symptoms, would that lead to kind of going to different specialists before really figuring out the correct specialist to see? Because you don't have the primary care doctor to kind of guide you to the correct specialist, and that could have financial consequences.
Absolutely. It's a balancing act between what's called gatekeeping, right, and free choice. So Germany's gone the free choice route. That's more valuable than the gatekeeping route, and they're willing to pay for it. Conversely, the Dutch have a very strong primary care gatekeeper. You cannot go to a specialist. The government or the insurance, the sickness funds will not pay unless you get a primary care referral to a specialist. France, more, while they have you get a referral, it's not enforced. And again, patients, free choice can go to specialists. Very different modes. The United States is more like Germany in this regard. You can call a specialist and go to a specialist. I'll just give you an example. Someone I know had, muscle pain, muscle aches. They called me and I said, well, I think you've got this disease, polymyalgia rheumatica. You ought to go to a rheumatologist. They made an appointment with the rheumatologist for the next week. The rheumatologist was open and they confirmed that diagnosis, but they didn't use the primary care doc system. So, yes, we control it by paying, by creating deductibles and high copays. But Germany, you don't have that big financial threshold. So you do get some overutilization, and they're willing to pay for that rather than have this strong gatekeeper model that other countries have adopted. So you're 100% right.
Mm-hmm. Maybe one last question, Pearl.
You already kind of covered this after I put my question in the chat, but I was just curious. I'm kind of thinking about countries like the US where there's high emergency department utilization by people who don't have access to primary care. Do you think there's an upside to having a lower threshold for hospitalization in terms of outcomes and also in terms of kind of follow-up care?
I would say no for two reasons. One, hospitals are extremely expensive, especially in the United States. So it's a very inefficient way of, what we call working up a patient. Second, almost no one likes to stay in the hospital. I think way back when, at some point, maybe in the distant past, being in the hospital, being taken care of was thought to be desirable. But as I like to say now, going to the hospital is not like going to a spa, right? The hospital may have lovely cherry furniture, a beautiful lobby. You may think you're in the Four Seasons, but once you get on the floor, it's pretty miserable, right? You're woken up every few minutes. Someone's taking your blood pressure, doing this. You can't get a night's sleep. It's noisy, right? It ain't no Four Seasons. And so I think by and large, people have realized, it might be good to get Granny in the hospital so I get a break. And that might be a way of getting a break. We used to, when I was training at the Beth Israel, we was like Friday, afternoons, the emergency was filled with grannies. Why? People wanted to drop Granny off at the hospital, go to the Cape for the weekend, come back, pick up Granny and take her home. We were very cynical about this. But you could see this sort of cycle. But it's well recognized that, patients at home recover faster for things that can be managed at home. And the United States leads the world in home care and leads the world in figuring out how to provide efficient home care. Still doesn't mean it's flawless here, but a lot of places are looking to deinstitutionalize care because institutional care is expensive. There are some places where it's not so expensive. Britain, for example, hospitals are still pretty cheap and they use a lot more hospital days than we do. All right, let's conclude with the advantages of the German system. Multiple competing private sickness funds. And again, I put competing in quotes. Free choice of sickness fund, physician, hospital throughout the country. Unlimited physician visits, as we were just discussing, no real gatekeeper models. Low copays for services, and sometimes no. Drug price negotiation and regulation, dedicated financing for long-term care. And I would emphasize also this special arrangement with kids where kids really don't, sort of socially subsidized, not targeted to kids. So families don't have to pay for the healthcare of their children. All right. Thank you. Hope this was valuable. Hope you like the book. And good luck in your future endeavors, getting into med school or whatever else you're doing.